right, so we're going to start on neoplasms this morning. First one we're going to talk about is the solitary pulmonary nodule. This can be a benign granuloma, or it can also be classified as a malignant growth. Cancer risks are listed here, so if you're under 30 years old and they find this, there's less than 1% of it being malignant. Between 30 and 45, there's about a 15% chance of it being malignant, and then 50 and older, there's about a 50% chance of it being malignant versus not. This has to do with a lot of different factors, mainly environmental. So the longer you are alive in the same area, you are more prone to environmental issues. Radon, if you don't have your house mitigated for that. If you live close to any sort of power plants or chemical plants or manufacturing plants, things of that nature. And also depending on your profession, as we talked about the last time, silicosis, asbestosis, depends on what you're exposed to through your job. And some of those can take years to develop. So it's partially where this percentage comes from based on age. Symptom-wise, a lot of times they are asymptomatic and they are incidental findings. A lot of this doesn't become symptomatic until these masses get fairly large and start obstructing either the main airways or blocking off alveoli without being able to do gas exchange. Radiographically, for benign tumors, they're going to have pretty sharp margins. As you can see here, you have a definitive, almost flat line, if you want to call it, around it. It's a very sharp margin. You can define that margin around that. Sometimes they're called popcorn calcifications. You heard that term a couple weeks ago. Because they're so small and they're kind of scattered around. Kind of resembles popcorn in the pictures. They do have a slower growth rate. These nodules usually double in size in about 1 month. And then it can take up to can take up to 18 months to grow in size to be either definitive on a X-ray or cause symptoms. If they are malignant, it will have a very ill-defined, irregular, and fuzzy border, what we term spiculated. So if you look on the picture here, you can see how you can see how it's kind of spiky, if you will. That's termed spiculated. It's kind of a fuzzy edge. It's not very well defined like we saw in the benign tumor where you can tell it looks almost like an egg, if you want to call it that. These are extremely rapid growing, which is very important to determine them early on. So you can see pictures side by side. There's the benign mass and the malignant mass. You can tell the difference between the two. So if you have this image on the test, it may give both pictures and say which one is benign or which one is malignant. Or it may just show the one picture and say this is indicative of a benign solitary pulmonary nodule or malignant solitary pulmonary nodule. That type of thing. So CT, you can see the benign, almost kind of looks like a marble or like an oval egg shape and cross section. With a malignant one, you can tell it looks almost like it's in the X-ray, spiculated edges, ill-defined borders. Imaging options, you said X-ray is the initial incidental finding. They do regular follow-up with X-ray to check the growth. They will also do CT for this. This will help demonstrate the size, density, position inside the lungs. As you know, X-rays are only two-dimensional. You can do AP in the lateral, but you can't really tell where inside the lung that mass is. Where CT comes into play for the cross-section, we can definitively away from the chest wall it is, how close to the heart. Its lobe is in lungs. May also show more nodules that are not visible on X-ray, which can help determine metastasis, and also show if it spreads to the hilum or the mediastinal region. PET scan will show an increase in metabolic activity, or an increase in cell division, would indicate rapid growth of metastasis. They also do percutaneous fine needle aspiration. This is actually a CT-guided biopsy, where they insert the needle through the skin into there, and they pull out the cells, and they can run the test on that to see what it's going on. And then they do removal, typically between the ages of 30 to 40, if the patient is viable for that option. They will go and actually remove that tumor, that growth, through biopsy. Bronchial adenomas. These are a very low-grade malignancy. These make up about 1% of all bronchial neoplasms. It's an equal occurrence between men and women. There's not one sex is more prone to them. It is more common in younger people than bronchiolitic carcinoma. So these arise beneath that bronchial epithelium, or in the bronchial mucus glands. This can cause obstruction in the bronchi. They are most of the time more centrally located than peripherally. There are three separate common types. There's a carcinoid, which is about 85% of all bronchial gland tumors. There's an adenoid cystic carcinoma, which is roughly about 10% of them. And then that mucoepidermoid carcinoma, which is about 1 to 5%. So you can see that carcinoid type is the most prevalent. Symptom-wise, as we said earlier, you need obstruction, you get cough, hemoptysis, recurrent pneumonia, as well as atelectasis. As we said earlier, the younger people are more at risk for this. So radiographically, what we're looking at. So larger adenomas can appear as a soft tissue mass, which can be taken on imaging, taken to look at as a soft tissue mass versus a bronchial adenoma, which is when they need to do more testing to figure out what it is or more imaging. 80% are found in the major or segmental bronchi. Again, some of those smaller adenoma may not be clearly visible in X-ray imaging. There are less complications if they're peripherally located than centrally located, where these can appear as a solitary pulmonary nodule. So on the initial imaging, they may think it's a solitary pulmonary nodule, and through further testing of the imaging, they may decide it's a bronchial adenoma. So as you see as we go through some of these, certain things can look like other things in imaging, at least in the initial stages. I don't want you guys to get scared like when I do that imaging for the tests. I'm not going to put an early stage bronchial adenoma on here and ask you whether it's a bronchial adenoma or a solitary pulmonary nodule. So you don't need to be concerned about that. It's going to be specific things like is it benign or malignant solitary nodule. You can tell the difference between sound smooth line, the other straight. So just kind of keep that in mind. But it's important to know that a lot of things can look like other things. So if you see this, that's why it's important for us not to give patients information on imaging. Because if we see this, they'll go, oh, that's a solitary pulmonary nodule. And it's not, it's bronchial adenoma. The patient may hear you, like overhear you talking about it, go home and look up a solitary pulmonary nodule. Realize it could be a non-normal malignant or anything else, and you start researching that, and you know, that with Google. But then the doctor calls and you're like, well, you have a bronchial adenoma. They're like, well, they told me I had this. Well, get in the middle of that place. So it's very important not to do that. This is one reason why. Is because a lot of people so as I said, the smaller ones aren't really that visible. A lot of the indications that could lead to this would be either pneumonia visible or atelectasis being visible, as well as this nodule, this adenomatous. So you can see here, this is peripherally located. You can see how at just first glance, it could look like a solitary nodule. Here on CT cross-section, along the periphery. So even though you'd say, oh, well, it's centrally located. Yes and no. Yes, it's central because it's next to the heart, but it's still peripheral in the heart. So centrally located would be in this region, along here. So treatment-wise, they do bronchoscopic surgery to try to remove it if they could, or at least take biopsy of it. And then again, surgical resection of the affected lobe, depending on the location and what other structures it's affected. In that first picture, if it's pushing on the main stem, bronchi, it could be closing off that airway, they definitely want to remove that right away. If it's kind of over here, you may kind of let it sit and watch it to see what it does a little bit before they go and do it. Bronchogenic carcinoma, also known as lung cancer. So anytime someone says they have lung cancer actually encompasses a lot of different things. But generally, if someone says they have lung cancer, it's bronchogenic carcinoma. It's kind of a synonymous term. A lot of people say lung cancer. But for our purposes, if you're lung cancer, it's referring to bronchogenic carcinoma. This arises from the epithelium and mucus glands of the bronchial tree. It is the most common primary carcinoma. It is a solitary pulmonary nodule inside the lung parenchyma. And there's also two different types. There's non-small cell and small cell. Causes are mostly unknown for this. However, it has been linked to smoking, inhalation of different carcinogens, air pollution, gas exhaust, industrial fumes. So there's three types of non-small cell carcinoma. So non-small cell covers about 80% of lung cancer. Squamous cell, adenocarcinoma, and then there's undifferentiated large cell carcinoma. So squamous cells about 30%, adenocarcinoma about 35%, and then the undifferentiated is about 15%. So in squamous cell, this arises from the central bronchi. It does cause narrowing of the bronchial lumen, which then leads to obstruction. Adenocarcinoma will arise from the periphery of the lungs. It can also be termed bronchiolar or alveolar cell carcinoma. But it's in that case, the bronchiolar cell, the alveolar cell, comes from or starts in the alveoli. And then undifferentiated also arises from the periphery of the lung. So squamous non-small cell, here. Cross-section of the adenocarcinoma. You can see here is just in the periphery. Now, small cell carcinoma is that other 20% of lung cancer. This does include a large amount of highlighted lymph nodes, very aggressive, very rapidly growing and causes early metastasis. This is also termed oat cell carcinoma. Correct. Yeah. Here's an image of small cell carcinoma. So diagnosis-wise, they're going to test the sputum. There will be cancer cells that are in there that are popped out from the lungs. They'll also do bronchoscope and biopsies to check the growth to see if it is cancerous or not. Symptoms-wise, there'll be coughing, hemoptysis, shortness of breath. Everyone knows what hemoptysis is. I know we've said it a few times. So they can either do the biopsies under bronchoscopy, so we'll insert the bronchoscope in, locate the growth, and essentially send a little claw out to like grab pieces of the growth. Or they can do it CT guided. We saw in the picture earlier, they'll just insert a needle through the skin into the tumor and pull out the cells. Who's at risk? Again, smokers and those who have any sort of exposure to inhaled carcinogens. Radiographically, obstruction isn't necessarily seen as itself. It is seen as secondary changes, so atelectasis or pneumonia. So the pneumonia will actually end up being distal to the obstruction. So you see there'll be no air bronchogram visualized because that obstruction blocks the airway leading to that area of pneumonia. You'll have unilateral enlargement of the hilum. This is due to primary carcinoma of the major hilar bronchus. Metastasis from smaller lesions in the lung end up spreading to the pulmonary lymph nodes, and that can also show as this enlargement. We'll also see some cavitation, some upper lung lesions that we talked about earlier with that caseous necrosis. You see that central necrosis in the middle of that lesion. You'll also be able to see those air fluid levels. So here, see a pretty large mass there. See, this is all in that hilar region, kind of where it starts and goes out. Here's that enlargement of the hilar as well. Early staging. So treatment-wise, there's a very poor prognosis. If it's a solitary pulmonary nodule, it can be surgically removed either as itself or as a full lobe of the lung. There is about a 10% cure rate via resection. You can see when it's resected, it still has a very low prognosis. Radiation therapy and chemo are palliative care only. They're not going to cure disease. They're pretty much used to slow the growth of the tumor. This typically metastasizes to the bones. Pulmonary mets. There are two different styles. You can have hematogenous spread or lymphatic spread. Either, in this case, it either spread to the lymph system or to the blood. And it does spread from musculoskeletal system, myelomas, breast cancer, urogenital cancer, thyroid, colon, esophagus, or stomach. Those are the ones that will primarily spread through the lung. About a third of cancer patients will develop pulmonary mets. Yeah, I mean that pretty much lists 98% of all cancers out there. So if they don't catch pretty much any cancer will spread to the lung if it's that's but unfortunately with some of them that's the only way they find it is they go in for a cough or chest X-ray to see it. So as I said, hematogenous means that it spreads to the lungs through the bloodstream. Lymphatic it will spread to the lungs through the lymphatic. To radiographically, when you see multiple well-defined round oval nodules throughout the lungs, you can see there'll be different types. So you're going to have fine miliary nodules, which are highly vascular. They're usually present throughout both lungs, with an upper and middle lobe predominance. And then you can also have some large, well-defined masses that we also term cannonball lesions.
Is this the same as cancer or
This is different. So bronchogenic carcinoma was lung cancer. So primary cancer was from lung. Pulmonary mets, is just what it says. It metastasized to the lung from somewhere else. So primary was from one of the systems that was skeletal, breast, whatever. And secondary would be the lung. So you could think of this as secondary lung cancer. This is lung metastasis. So if it comes from the thyroid, it is a low-grade malignancy, thyroid cancer, but it essentially causes a snowstorm metastasis, where when you look at the picture, it will look like it's snowing. You'll see tons of little dots all over from that nodule. They are very slow to materialize on radiograph because they are so small. Through lymphatic metastasis, will show coarse interstitial markings. They'll have very irregular shape, poorly defined margins, and these will be most prominent in the lower limb. This is thyroid, so you can see that snowstorm effect. So this is actually very late in this process, because you're not going to see it for quite a while. So here's the lymphatic. It's most prominent in the lower lobes. Here is lymphocytic mets. So this came through the lymph system. So this first picture came from breast cancer through the lymph system to the lungs. You can see it's how it's primarily in the lower lobes here. You can see there's other issues going on about the lungs. Here. Cervical cancer mets. You can see they're larger, solitary nodules throughout the entire upper limb. Solitary nodules. So here it's pretty easy to see what's going on in it. If it's just a solitary nodule, it may be missed on X-ray, especially if it's sitting behind the mediastinum or behind a heart, or in that one image I showed. So if it's, let's ignore it that this is here. So let's say if it's hiding like right here, or in here, or even like right against the wall, and it's tiny, it can be hard to miss, or it can be easy to miss on an X-ray, which is where CT is better to find these solitary nodules. Alright, so initial finding, we've got this solitary met right here, which can be seen on X-ray. As you can see, it's a very blown up image, but if we had our normal X-ray up there, we may not be able to see it. This is something a radiologist would find with their training. And even still, like Deb said last week, even radiologists and other physicians use those books you had on that card to look through and figure out. Because they don't see a lot of the stuff every day. They have an indication that something's wrong because they know what it's supposed to look like. They don't know what's wrong. They have to do what it is too, or they do studies. In either case, this is something that could be easily missed a normal size X-ray. But blown up, you can't see it. Here's 5 months, same patient, 5 months later, you can see that this one has grown, but then there's also this one right here that has grown. Which means this one was existing, hiding behind the diaphragm, which was under visualized, which is where CT and look at the cross section and see. That's why a lot of cancer patients have a lot of imaging done between X-ray and CT throughout their entire stage of the treatment process. So some new technology for diagnosis for pulmonary mets. Not necessarily new anymore, even though PET scanners are becoming more technologically sound, I guess, if you will. They can detect things better than they used to be able to. And it can help demonstrate cellular activity to see where this could be split. Now we're going to move on to vascular diseases. So pulmonary embolisms. This is essentially a clot that breaks off from a thrombosis in the legs that then travels into the heart and gets lodged in the pulmonary arteries. It could end up being a blockage of one or more pulmonary arteries. It is potentially fatal, depending on how big the clot is and how long the patient is dealing with symptoms. As I said, it does come from a DVT or a deep vein thrombosis. So a lot of times, if you have a patient coming in with chest pain, they'll do an ultrasound of their lower legs, and then they'll order CT angiogram for pulmonary embolism. Even if the ultrasound comes back negative, they'll still do the CT just because they could have had it. The chest pain shortness of breath. Most of the time, it starts off with shortness of breath on exertion, and then it's just constant. Most of the time, you'll find these in the lower lobe. A lot of times, they're very hard to see on CT when they're down this low. But you'll know if there's a larger facility. So outcome is based on the size of the embolism and how much circulation is blocked by it. You can see here's that vein in the leg, that embolus breaks off, travels in, gets lodged in the bone. Symptom-wise, 80% of patients show no symptoms, or they have very mild symptoms. So who's at risk? People who are on bed rest, since they have prolonged mobility, very long airplane trips, very long car rides, things like that. Elderly patients, they are more sedentary by nature. Family history of any clotting disorders, certain medical conditions that can have issues with clotting or excessive clotting. Recent surgery, and then lifestyle. So some medical conditions that I want to go through real quick. Any sort of valve malfunction. There's little tiny valves that are separated every few inches within all the veins that help keep the blood moving in the right direction. They open up the blood back through the heart and the closure of the way so that venous flow can't filter back out. If there's any malfunction with those valves, that blood can sit there and can then coagulate through the valves. Dehydration. Older people are at a higher risk of dehydration, which can thicken the blood and cause it to clot more easily. Heart disease, so high blood pressure and other cardiovascular disease also correlate to this pregnancy. So depending on where the baby is sitting and the weight of the baby, it can press against the veins and also cause that clotting over. As cancers, especially pancreatic, ovarian, and lung, can also increase levels of substances that help the blood clot. And then chemotherapy can also help increase the risk. So surgery is one of the leading causes of blood clots, typically with joint replacement of the hips and knees. So essentially with that, there's tissue debris as they open the patient up to the surgery. Some of that tissue debris can get into the blood supply, and that can cause a blockage as it flows. Lifestyle, smoking, obesity, and birth control pills. So smoking, obviously for reasons that smoking causes a lot of health issues, but they don't really understand why smoking is a high prevalence for teens. They feel it has something to do with the tobacco, with the targets in there, but there's really no known about smoking. People who smoke at a higher prevalence for pulmonary. Obesity, excessive weight increases the risk of blood clots. This is more so in women who smoke and have high blood pressure who are also who can have a trifecta there. Blood control or birth control pills. So the estrogen in the pills and in certain hormone replacement therapies can increase the clotting factors in the blood. Again, compounded on if you smoke and feel it. So pretty much most patients who smoke and are overweight are going to have even a higher prevalence with other factors kind of in their pregnancy, other health issues. Imaging-wise, X-ray, you're not really going to see anything. You're not going to see an embolus on an X-ray. There can be a decrease in blood flow. So you could see an increased density in that area of the heart. But it's not really going to be based off a single. That's with an embolism with no infarction. So essentially, it's not cutting off the full blood supply to the lung tissue that you're not going to see anything. If there is infarction, there will be an area of lung consolidation. You will also see what's termed a Hampton's hump, which is a shallow wedged-shaped opacity in the periphery of the lung, with its base against the pleural surface. It can resemble pneumonia, and also you may see pleural effusion. So they'll do also radionuclide scans, a VQ scan, which is essentially a ventilation-perfusion ratio scan that's done through nuclear medicine, high-res CT, or a pulmonary arteriography, and then MRI. So a high-res CT is preferred. The pulmonary arteriogram is high-res. This is actually like an IR procedure. Which is more high risk because if they try to go into the catheter, they can dislodge it and put it down. Here. So here's that Hampton's hump. You can see right here in this blown up picture. Right here in the larger picture of the blown up. This is what's termed Hampton's hump.
So that is infarction.
Yes. little here. Look a lot better than CT. Actually, don't show the embolism in this image there. So this is the IR pulmonary angiogram. You can kind of see it right here. In the blown up picture, here's the clot. Completely obstructing with no blood flow. So treatment-wise, we can do some anticoagulant therapy. We'll do some thrombolytic therapies, and we can put in an IVC filter to help catch those clots before they get all over. Septic embolism. This is essentially an embolism that is infected with bacteria. If they arise from the heart, it's from bacterial endocarditis, or if it's from a peripheral vein, it's septic thrombophlebitis. Who's at risk? Pretty much people who have a history of IV drug use. Radiographically, you can see multiple emboli. They'll be well ill-defined. You can see that Hampton's hump again, and you can see some cavitation, as we do with abscesses. So here, that's septic emboli. See that area of cavitation in the middle. Here. There's multiple masses with that cavitation in orange. And again, the fluid level with that cavitation. Treatment-wise, pretty much antibiotics to just destroy the infection. Depending on how large they are, they may be able to try to drain some of it with the needle aspiration. But mainly antibiotics to help destroy the infection and cause it. Pulmonary arteriovenous fistula. So this is an abnormal connection or a fistula. We talk about fistulas. You guys know what fistula is? So it's essentially, they're more prevalent in like the esophagus. Like there's esophageal fistulas. There's fistulas between the rectum and the wall. There's a lot of different types of fistula. Fistula just means there's an abnormal connection between two things that shouldn't be connected. The fistula in the heart but a fistula means there's just two things that are connected that should be. In this case, it's an artery and a vein that are connected together. This causes a lack of oxygenation. So if not only arteries send out deoxygenated blood to the rest of the body, the veins and the system bring the deoxygenated blood back to the heart to be deoxygenated. In this case, so for this, in this fistula, there'd be a connection essentially between the pulmonary artery and the pulmonary vein. So as the oxygenated blood, or deoxygenated blood comes in and gets mixed, it doesn't get pushed back out. Some of it gets pushed back into the heart. Some of the deoxygenated blood gets pushed out to the body. So it's kind of like a turbine. It just keeps kind of getting mixed and doesn't get pushed the right ways. So in this instance, the deoxygenated blood is passed through the pulmonary artery to the pulmonary vein, and it's allowing that deoxygenated blood to get passed through the body, which is not going to help. You're not getting oxygen to the body. You can help starve those organs and that tissues, and they can start becoming necrotic if you're not getting enough oxygen. So because most pulmonary, what we term AVMs or arteriovenous malformations, or these fistulas, are found in the lower lobes. In the upright position, more blood will be directed toward the lower lobes due to the gravity. So they'll have orthodexia or a fall in the oxygenation. So if you stand a patient up and the O2 stats drop, they could have this condition. Does that make sense? That's what that's saying. So you kind of know if they go in an upright position, let's say Josh is standing at 98, sitting down in bed, stand him up, he drops down to 80. Like, well, most of the time you'll know these patients have this condition, so you're not going to want to do that, but you have to do a chest X-ray to keep them down. But just keep in mind that that is going to cause essentially orthostatic, memory hypertension is orthostatic saturation. So treatment-wise, you can see here, well, here's kind of a picture of the pulmonary artery and pulmonary vein. This purple line should not be here. So this is the deoxygenated blood coming back into the pulmonary artery, which should go to the lungs, get oxygenated, come back to the heart, and get pumped out through the pulmonary veins. So that connection then causes that deoxygenated blood to get pushed in with the oxygenated blood, get sent back to the heart, get pushed out to the heart. Does that visualization make sense?
Is this like a specific to the pulmonary artery and vein, or it can be between any like artery and vein in the
This is specific
to
to.
those?
So there are AVMs or arteriovenous malformations that can occur throughout the body. Primarily, they will occur in the brain, which we'll talk about when we talk about brain things. But it causes the deoxygenated blood to circulate together where it can't get passed around as it normally should. This is kind of what this is showing. Is this is specifically to the heart right now. This is a pulmonary. So in the lungs, pulmonary arteriovenous. So symptoms, you can have some bloody sputum, difficulty breathing. Who's really at risk? So genetic-wise, people who have HHT or hereditary hemorrhagic cholangioplasia, or it can be secondary to liver disease or lung injury. Radiographically, we're going to see some round or oval lobulated soft tissue masses, typically in the lower lobes. So here, you see it here. But again, what does this look like? Anything in the lungs. So, I mean, that's why there's a lot of other testing that needs to take place to figure out what some of these things are.
So this can be developed, or is this something that's genetic?
Both. So it can be genetic if they have that HHT factor, or it can be caused by any sort of lung. So liver disease. So it can be secondary to liver disease or lung disease. So if you have certain liver diseases, which we'll talk about later in the road, it can cause this to occur. Or if you have any sort of lung injury, if there's damage to the vessels, and they try to repair themselves, they can repair themselves incorrectly. Or genetically, it will be part of this ADHD.
But
So that's why it occurs in lower lobes, because if the deactivated blood just comes out of the heart, the tissues there are still getting more oxygenated blood than the deoxygenated blood right after it leaves the heart. It's not until down the line that then deoxygenated blood keeps getting to that lower area and it can't get filtered out, that then it starts creating this. So on X-ray, you kind of see it here. So treatment-wise, they can do embolization, essentially to close off that area, that incorrect connection. Embolizing means just bringing the tissue away to close that off. And then surgery, they can actually go in and surgically repair it, remove that fissure out, repair the walls so they're separated. As before, see this soft tissue next one here. Again, that's CT. On a arteriogram, and then after, looks like they may have thrown boiler. It's kind of an embolization procedure they did, but they essentially blocked it off so you can't, so that passes no longer. Like a little foil that's keeping the blood. Miscellaneous lung disorders. It wouldn't be a stent, it would be a coil. So even if they put a stent in, the stent may fail. So typically when you stent something, it's to keep clots from forming and to keep if they stent it, that's still going to allow this blood flow to go between the stent and the wall of the lumen. So yes, it will mitigate some of it, but it won't completely stop. Where they have to go in and cut this out and essentially patch up that wall and that wall, or they embolize it, where they essentially burn, they cut and burn these two ends, so it's like seal off this end, seal off this end. Or if they coil it, essentially think of a coil as a bolt spring. It's just a metal bolt spring. It's a ball of just metal, or of metal coiled up, very, very tiny wire that they would stick right inside here that would essentially cause everything to clot around it and seal it. That's kind of what they do with aneurysms in the brain, or coils. Essentially force them to clot on themselves and stop growing. miscellaneous lung disorders. So we have ARDS, or acute respiratory distress syndrome. In 1994, they changed it to acute. It used to be called adult respiratory distress syndrome. They changed it to acute because they realized that it's not necessarily only adults that can get it, children can also get it. So they couldn't very well keep calling it adult respiratory distress syndrome. So they changed it to acute respiratory distress syndrome. It is a very serious reaction to various forms of injuries or acute infection in the lungs. It is an unexpected respiratory distress, which is why it's called acute. It is essentially a fluid buildup in the alveoli. So you see a normal alveoli, and there is the fluid-filled alveoli. It is characterized by inflammation of the lung parenchyma, leading to impaired gas exchange. Hypoxemia is also a very real concern with this. It is life-threatening because it prevents oxygen from getting to the lungs as well. This does make the lungs feel very heavy and stiff, decreasing their ability to expand. So if someone comes in and says there's an elephant sitting on their chest, they could be suffering from ARDS or another condition, but that's kind of what it's typically from infection, so it could be the infectious material that gets in there, not necessarily from. It's typically caused by an infection. If you just say it's from mucus, it could be anything, I guess. Correct. So yeah, we're going to get through. They're going to do inspections. They're going to do the breathing therapy, scanning therapy. So this will occur with failure of other organs as well. So if people have liver failure or kidney failure, it can also lead to this condition. So severe infections, sepsis mainly, any sort of chest or head trauma, expiration, inhalation of toxins and irritants, severe pneumonia, drug overdose, or in other critically ill patients. Pretty much chest or head trauma. The chest trauma would typically be injury to the alveoli or capillary membranes, where that fluid, whether it may be blood or lymphatics or cells to fight off infections, things like that, will get trapped down in there. Radiographically, you're going to see it bilateral. It's not just going to be stuck to one or the other, it'll be both. You'll have some ill-defined areas of fluid-filled alveoli. It's going to look patchy. So treatment, they're going to do diuretics to help reduce the amount of water in the body, help expel some of that extra fluid. Oxygen therapy to help contract and expand the lungs to help push that fluid back out. And then hyperventilation to help push a lot of oxygen back in there to help expand the lungs. Intrabrachial foreign bodies. So this is essentially aspiration of a foreign body into the tracheobronchial tree. Usually travels to the right lower lobe. Why is that? Do you remember? So the right brainstem is more vertical. Good. It is more common in children. um, mainly because they like to shove everything they can in their mouth, no matter the size. Um, it can cause either partial or complete obstruction of the airway. Um, and then, if it's a partial obstruction, it allows air to enter the distal bronchus, but air is then trapped, and it cannot escape during isolation. So we have hyper aeration of the lungs. And a complete obstruction will lead to atelectasis, or partial collapse of the lung. So symptoms, difficulty breathing, coughing, even young children are at risk. Elderly are also at risk, depending on what other health conditions they have. They may not be able to chew as well. If they wear dentures, they may be loose and not being able to chew very well. Things like that.
You talk about aspiration, is that what's going on?
Correct. So we need to form any issue with this area. Radiographically, again, you're going to see complete atelectasis, or atelectasis is a complete obstruction, or hypertension is a partial obstruction. Treatment, they'll do some expectoration. They can do a bronchoscope to go in there and try to retrieve the item. Depending on where it's lodged, what's lodged, and they have to go in surgically. So here is a backing of the earring, and I'd probably say 2-year-old. Then here is a nail. You see it? There's another nail here. There's the safety pin. Yeah, I mean that's common swallowing, crown swallowing things. A little bit different. This is more aspiration, so it gets sucked into the airway. But I had a seven years. There was a woman who was a seamstress who had all of her push pins in her mouth, walking downstairs, fell and swallowed all of them. We took flat paste on her for a good week, trying to track all of them. They were probably 20, 30 of them. Yes and no. I mean, that's kind of a small thing. So let's say they didn't know the kid swallowed it, and they just thought the kid had a cold or something, and they waited a week before they brought the kid in. That could puncture all the way through that stem bronchi. If it just happened, they came in and they found it. The likelihood is maybe if it punctured once or twice, it would heal itself up. Like it's kind of a small thing. Now the nail could cause more issue than this. Even the earring gap, depending on how big it was or what shape it was, it could have cut the internal lining. So it all depends on what's swallowed. Easy to do like this, they could probably go with bronchoscope and carefully pull it out. Then now they may have to go surgically. It all depends on where. If it was, let's say, still up here, it'd be a lot easier than all the way far. So let's skip. Skip a couple slides here, so I guess I deleted the slides on atelectasis. So I'm just going to talk about atelectasis for a little bit. Actually, did we cover atelectasis? I don't know why it's. As I'm looking at this, I'm like, I'm pretty sure I said all that. Okay, ignore that. There is. mediastinal emphysema, or also known as pneumomediastinum. This is essentially air within the space between the lungs. So the air essentially leaks from a lung or the airway into the mediastinum. So basically, as you were saying, if one of those things is punctured through that main stem, it could then lead to this. Cause typically spontaneous due to stress trauma or tracheal perforation from the foreign body, or increased pressure in the lungs can also cause this. So increased pressure here. I think of scuba divers. Some of the things could be indicating this. This can cause scuba diving. So if they have a rapid rise in that elevation in the water, it can actually cause the trachea to tear, which will let that air escape. So symptom-wise, you're going to have chest pain behind the sternum that can spread into the arms and neck. Typically, with small amounts, the body will reabsorb the air. But if you think if someone has a cholecystectomy, have the gallbladder removed, they essentially inflate them with air so that they can see and move a lot easier. They don't then put a little valve in there and release all that air when they're done. It kind of always sits in it. It's slowly reabsorbed by the comfortable for a few days until that happens. Same thing here. The smaller issue, even larger ones, the air will eventually reabsorb back into the body. Just because longer depending on how much air has escaped. Can lead to a collapsed lung due to that air leaking from the lung. Air will then pull up. That air builds up in that pleural space, which then allows the lung to collapse. So radiographically, what we're going to see here, we can have the mediastinal pleura here appears long, like that long linear line. You can see it right where these white arrows are. That little white line going right there. That's the pleural lining right in the mediastinum. That air leaked out and is separated, that lining from the mediastinum wall. Here you can see the same thing, except it's a lot larger on that side. You can also see it up in the shoulders and in the neck region. You can also kind of see it out in the shoulder here. Close-up picture, you know, that line. Here, that here, there's that here in the mediastinum. CT, and it shows it a lot better. Again, along the chest wall. Here's a very severe case of all that is up in the sternum. So the lungs have also collapsed on both sides. So in infants, you're going to see an elevation of the thymus, or what we term the wind-blown sail or angel wings sign. The wind sail sign is when the entire thymus shifts to one side, where the angel wing sign is where both lobes are shifted upward. So here, you have that wind sign, or that wind sail, or that spinnaker. That sail, they call that sailboat. The smaller one is called the spinnaker. So it's kind of what that looks like. If you think of like, if there's a sailboat here, you have a larger sail here, a smaller sail in the front. That's why it's called that wind sail. And then here, we have the angel wing sign. Both lobes get shifted up, where it looks like angel wings. Again, some more pictures. Here's that elevated thymus. pleural space. Now leading into subcutaneous emphysema. This is where air escapes into the tissues under the skin. This will occur in the skin of the chest wall or the neck. You'll hear a crackling sound or sensation when you breathe, or when you push it. It feels like you're pushing on Rice Krispies. What is it? Correct. So the mediastinal fits so that in the lungs or the trachea leak into the mediastinal wall, and then that is up in the neck. Correct. So the subcutaneous can be an effect of mediastinal if it gets up in the neck. Subcutaneous is separate from mediastinal. It is not in the mediastinum, it's just in the skin. So this is typically caused by penetrating or blunt injuries. As you can see here, this is a picture of this gentleman. You can see under his eyes. How his neck looks very puffy. This is all air inside. This is after dissipating. Well, right. So you're going to be able to see whether it's edema or air. So this, my guess is, he had some sort of trauma. Let's see if you can see here. So you see that patient, you'd be like, oh, he's got a lot of swelling. What it could be? If you take his images, you can see it's kind of a darker image, but see on the periphery both sides all that streaking. So this is all air in the subcutaneous tissue on both sides. See all the streaking coming in this way? It's just separating all of the muscle fibers, all of the skin.
So what is the pore?
Where is what?
To go into the tissue. Where does the tear have to happen in the lung?
Anyway, any trauma, if you have like any, you have any, you could get multiple trauma on the sides, the front, the back, anyway, it gets the
Doesn't this happen to surgery as well?
It can, depending on the.
Maybe for something?
It can. Yeah. The worst case I've ever seen was, I mean, this is bad, but this guy was even worse. He looked worse than the guy, the picture of the show. He was in a motorcycle accident. Yeah, his entire body was huge. Worse, like, you couldn't even see half of his skin underneath because it was so long. Here on CT, you see all the around. So there's really no treatment for minor cases. The air that's will get reabsorbed into the body. Severe cases, they may have to do surgical resection to remove areas of damaged tissue. Depending on how bad it is, it can actually destroy the muscle tissue and the skin tissues. You have to remove to release that pressure. Some things that can cause that subacute emphysema: rib fractures, facial bone fractures, ruptured bronchial tubes, ruptured esophagus, any sort of blunt trauma, stabbing or gunshot wounds. Disorders of the pleura, pleural effusion, which is essentially this fluid in the pleural space around the lungs. So if we go back to this picture, you see how here, it's instead you'll see like fluid in similar causes of that. So here you can see down here fluid built up in the fluid space. So congestive heart failure, pulmonary emboli, infection, some neoplasms, or certain abdominal diseases, and clotting. Smaller fusions are typically less than 500 milliliters, and then larger ones are usually have to go with tubes. Symptoms, you can have severe chest pain, cough, shortness of breath, tachypnea. So radiographically, you're going to see some blunting of those phosphorescent angles. You can see upward concave of that fluid level. So for smaller effusions, the lateral decubitus is best to visualize that fluid. It is also better seen on a lateral chest X-ray than a PA. And it can appear as pleural thickening or fibrosis along that chest wall. For larger effusions, they may obscure the diaphragm and the aortic heart. They also displace the heart in the mediastinum to the opposite side, but that's in very extreme cases. Treatment, they'll do a thoracentesis, essentially a drainage of the fluid. In this, they're doing a needle thoracentesis. Sometimes we'll actually into a chest tube, let it drain that way to the whole idea. Yes. Yep. So as you can see here, this is all fluid in here. You can see how we became the concave section here. Here you can see the lung kind of maybe over to it. Yeah, this is all the fluid right down here. And yes, it does lead to lung collapse. Here you see that little line there. This is all the fluid on this part here. Yep.
Okay. So when you look at the image on the left, how do you know it's fluid versus the lung is not collapsed? For like exam purposes, like how do you know that bottom is not collapsed versus it's fluid? Because it has the
So with I pulled up my analysis page, so I want to see what the differences are, so I'll tell you everything. So you in atelectasis, so lung collapse, you're not going to see anything. Like if a lung is collapsed because the air escapes, this is going to be all black. You won't see lung markings, you won't see anything. It'll just be all black. And the lung, you'll see the lining of the lung here, and then everything under will be black. You know this is fluid because it's white, which means it's a pleural effusion. Does that make sense? So that's how you know whether it's just a collapsed lung or pleural effusion. But pleural effusion, if it gets large enough, can lead to a lung collapse. You're not going to, you can pretty much assume if there's enough fluid there, the lung is collapsed up. Because that fluid has to have someplace to go, which pushes that lung out of the lung. Does that make sense? So decubitus, you see that there's fluid level. Again, here this is a very small one. On an AP, you wouldn't be able to see it because it's hiding behind the diaphragm and the heart. On the lateral, you can see that blunting of the phosphorescent angle. I've only got 3 minutes to finish up this chapter. So we're going to walk through it. Empyema is caused in pleural space due to infection. It is a very rare occurrence. It is usually caused by infection or thoracic surgery. As you can see here, there's an abscess with the pus formation, or even Radiographically, it's going to resemble pleural effusion. As it worsens and collects, it can appear as a mass. Or pleural effusion will still look like fluid. This will end up looking like a mass. Treatment will be fluoro-guided needle aspirations. They also require chest tube placements. You can see here, it kind of looks like it's a pleural effusion. You can see that line right there. So you can change the difference. Here, the only way they would know that this was an edema is if they actually went to drain it and realized it was pus and not. Actually,